And welcome back, everybody. I hope you all had a chance to check out our sponsor and exhibitor booths. It's now my pleasure to welcome Tom Halloran, President and CEO of Fideliscare, who's going to introduce and moderate this afternoon's panel discussion, Turning to Tech Post-Pandemic. Good afternoon, Tom.
Thank you, Eric. Good afternoon. It's my pleasure to introduce our next panel to moderate the discussion, which will look at the role that technology played in making care accessible to patients during the course of the pandemic and the prospects for helping to address systematic challenges in healthcare moving forward. I'm going to start the session with a presentation from Robin Gelburd, President of Fair Health. As the founding president of Fair Health, Robin built the organization into a trusted national leader in healthcare cost transparency, data analytics, and benchmarks, utilizing its vast collection of 34 billion private healthcare claim records that grows at a rate of over 2 billion claim records a year. Prior to being recruited as president of Fair Health, Robin served as general counsel of the Medical Research Foundation, comprising approximately 30 premier academic medical centers, hospitals, and research institutions in New York State, and as a health law partner at a New York City law firm. Joining Robin is Assembly Member Clyde Vanel. Elected to the New York State Assembly in 2016, Assembly Member Vanel serves the 33rd Assembly District of Queens, New York, encompassing the neighborhoods of Cambria Heights, St. Albans, Hollis, Queens Village, Belrose, and parts of Floral Park. He is also the Assembly's chair of its Subcommittee on Internet and New Technology. He previously served as the Chief of Staff for New York State Senator James Sanders Jr. and is the owner and operator of Vanel Law Firm, where he focuses on intellectual property law, business law, wills, and estate planning. Also with us is Gil Addo, CEO and founder of RubiconMD, a digital health platform that allows primary care clinicians to access same-day opinions, or e-consults, from top medical specialists to improve patient care. Prior to founding RubiconMD, Gil was a consultant at Putnam Associates Pharma Strategy Consultancy, where he designed payer and market access strategies for Fortune 500 clients. Previously held strategy and business development roles at Xerox, Cubist, and 2 early-stage healthcare ventures. Next, we have Shanel Fields, founder and CEO of Mdli, a 911 telehealth company that allows dispatchers and first responders to connect non-emergency callers to more appropriate levels of in-network care. As the daughter of a volunteer EMT, she launched Mdli with the desire to close gaps in care by integrating telehealth into 911 and allowing non-emergency callers to be connected to a virtual medical and mental health resources. As a telehealth thought leader, Shanel also serves on Techstars board of directors. Finally, we have April Coe, co-founder and CEO of Spring Health, comprehensive mental health benefit for employers. Previously, she was the chief co-founder of Spylight and is a Yale Entrepreneur Institute fellow. More detailed information on our panels are available by clicking on the speaker icons. So at this time, I'd like to welcome all the panelists. And I'm going to turn over the session to Robin before we go into the formal discussion. Robin?
Okay, thank you, Tom, for that introduction. It's really a privilege to be addressing you all today. In this presentation, I'll review how telehealth has changed over the course of the pandemic. I'll share New York as well as national and regional trends in telehealth utilization, as well as costs for these services, to shed light on how this venue of care is continuing to evolve. For those less familiar with Fair Health, we are a national, independent, not-for-profit created under New York law and established to bring fairness and integrity to health insurance information. We, in effect, were created out of a national demand for a standardized, comprehensive, and trusted data source to help all stakeholders exhale and have confidence in the information presented. We meet that need by having the largest collection of private insurance claims in the country and by being prudent stewards of that data. We actually now have over 35 billion, not 34 billion, it's already grown, private insurance claims from 2002 to the present. We receive over 2 billion new claims each year. In New York, we have a total of 3.4 billion claim lines to date. The data are organized into 493 discrete geographic areas or geozips to help capture the relevant healthcare market. Such markets tend to track with the first 3 digits of a zip code. New York, for example, has 31 distinct geozips. The The data are received voluntarily, typically monthly, from approximately 70 national and regional payers and third-party administrators, and reflect both self-insured and fully insured covered lives. Our independence, coupled with the breadth of the collection and robust auditing and validation methods we use, helps engender trust in the data and, in turn, trust in the institutions utilizing our data. I should note that we are also a national qualified entity as certified by CMS, which means we have been entrusted with the entire collection of Medicare fee-for-service claims, parts A, B, and D. The QE collection accounts for another 37 billion claims separately housed from our commercial claims collection. Fair Health uses its data to advance research in a variety of ways. For example, when there is a public health issue of great concern, we engage in internal research and release free data briefs and white papers to help bring greater understanding to the issue in question. With respect to COVID-19, we recognize that Fair Health data could play a unique role in illuminating the impact of the pandemic on the various healthcare sectors and patient cohorts. Accordingly, we have released a series of free COVID-19 related briefs, which have been widely disseminated and utilized in a number of ways, including being used to determine vaccine prioritization protocols. You can find all of these free studies on our website at fairhealth.org. Likewise, once the pandemic hit our shores, Fair Health determined to tap into our extensive telehealth data collection and provide a clear window into this evolving venue of care. Toward that end, we launched the free interactive monthly telehealth regional tracker that uses Fair Health data to provide insights into the evolution of telehealth in every region of the country. You can likewise access the Telehealth Tracker on the homepage of Fair Health's website. The original iteration of the Telehealth Tracker, launched in May 2020, compares a month in 2020 with its corresponding month in 2019 to show the dynamic changes in utilization associated with virtual visits before and after the onset of the pandemic. An interactive map of the 4 US Census regions allows the user to view an infographic on telehealth in a specific month in each region or in the nation as a whole. Each infographic includes findings on the volume of telehealth claim lines, urban versus rural usage, the top 5 telehealth procedure codes, and the top 5 telehealth diagnoses. Here you can see a sample infographic from the tracker that provides national telehealth data from July 2020. The next several slides provide some samples of data from our 2020 telehealth tracker. Here we are viewing how telehealth usage as a percentage of all medical claim lines changed during the pandemic in New York, the Northeast, and the nation as a whole. In January, telehealth accounted for approximately 0.1 to 0.2% of medical claim lines in these 3 regions. In April, near the start of the spring wave of the COVID-19 pandemic, telehealth claim lines increased to 16% in New York, 19.7% in the Northeast, and 13% nationally. Telehealth was likely viewed as reducing the risk of COVID-19 transmission associated with in-person visits. For that reason, patients and providers turned to telehealth. In some cases, federal and state regulations related to telehealth were relaxed, and private payers expanded access to telehealth. In addition, widespread restrictions on elective in-person procedures made telehealth a viable, indeed a critical option. However, as those restrictions expired and the country began to reopen, telehealth utilization declined as a percentage of all medical claim lines. And by August 2020, telehealth accounted for 5.1, 6.5, and 6.1% in New York, Northeast, and the nation, respectively. We see telehealth claim lines begin to rise again slightly in December, which was likely a result of the growing number of COVID-19 cases in the US during this time. Here we are reviewing the top telehealth procedure codes in New York, the Northeast, and nationally, starting in April 2020. In April, when we were experiencing the first wave of the COVID-19 pandemic, the services most commonly performed via telehealth in all 3 locales were established evaluation and management services and psychotherapy visits of varying lengths. CPT code 99442, which is a telephone visit of 11 to 20 minutes, was the 5th most frequently used procedure code for telehealth in New York, the Northeast, and nationally. By December, evaluation and management services and psychotherapy visits dominated the top procedure codes conducted via telehealth, while telephone services of varying lengths followed closely behind in the Northeast and nationally, although not in New York State. It should be noted that telehealth psychotherapy visits climbed in the rankings in all 3 regions, showing a persistent demand for mental health services during the COVID-19 pandemic. Now let's move to the top 5 telehealth diagnoses in 2020. In April, mental health conditions was the #1 telehealth diagnosis in New York, the Northeast, and the nation. Its distribution was quite even across locations, comprising 36.1% of telehealth claim lines in New York State, 35.3% in the Northeast, and 34.1% nationally. The other top conditions were joint soft tissue diseases and issues, hypertension, and general signs and symptoms, which had not previously ranked among the most common telehealth diagnoses. This suggests telehealth was being used for conditions not treated via telehealth before the pandemic. Mental health conditions share of telehealth claim lines grew substantially in all 3 geographic views by December, comprising 53.1% in New York State, 52.7% in the Northeast, and 47.2% nationally. December also saw the addition of COVID-19 and exposure to communicable diseases to the top 5 telehealth diagnoses in New York, the Northeast, and nationally. This was likely related to the holiday surge in COVID-19 cases as patients contacted providers via telehealth out of concern they had been exposed to the virus and or had contracted it. Substance use disorders emerged as the 4th most common telehealth diagnosis in New York. This is consistent with an increase in substance use disorders during the pandemic that have been reported by the CDC. It is also consistent with a trend toward the use of telehealth to treat a wider variety of conditions. Let's now turn our attention to the age distribution of telehealth utilization in 2020. In New York State, 21 to 35-year-olds accounted for the greatest share of telehealth usage. In the Northeast and nationally, however, we see that telehealth was more commonly associated with the 0 to 20-year-old age group. The older population, those aged 65 and older, made up the smallest share of telehealth claim lines at 8.1% of the distribution in New York, 7.9% of the distribution in the Northeast, and 5.9% of the distribution nationally. However, it should be noted that those aged 65 and older reflect only those in our Medicare Advantage collection. But even if we included Medicare fee-for-service data, that cohort would still likely trail the other groupings. But when we focus solely on asynchronous telehealth data, the 65 and older cohort outdistanced all others in 2020 and compared relatively evenly to the 51 to 65 age group in 2021. Now let's turn more specifically to 2021. A year after launching the monthly telehealth regional tracker, Fair Health enhanced the tool to offer additional insights into telehealth's evolution. Rather than comparing the same month across years, 2019 versus 2020, the updated tracker offers a month-to-month comparison of telehealth's continued evolution. The data fields evaluated in the new tracker include telehealth's volume of claim lines, top procedure codes by utilization, top diagnoses, and top mental health diagnoses. The new month-to-month tracker helps stakeholders obtain a better understanding of whether the increases in telehealth utilization during the surging months of the pandemic have continued, plateaued, changed in substance, or decreased as we have moved past the initial onset of the pandemic. Here's a sample infographic of the revamped telehealth tracker to give you a flavor for how it has changed. Now let's go back to the data. Here we are reviewing how telehealth usage as a percentage of all medical claim lines changed thus far in 2021. Month to month, telehealth usage saw a steady decline in New York, the Northeast, and nationally. In January, telehealth comprised 6.1%, 8.2%, and 7% of all medical claim lines in New York, the Northeast, and the nation, respectively. By July, however, telehealth utilization fell below 5% of medical claim lines in all three areas. The decline in telehealth utilization appears largely to be driven by the return of non-mental health services from telehealth, where they had previously shifted during the COVID-19 pandemic to in-person settings. In 2021, psychotherapy visits have become even more prominent in the rankings of top telehealth procedure codes. 60-minute psychotherapy became the most common telehealth procedure nationally and in the Northeast. A 45-minute office visit dominated New York's list of top procedure codes, with a 60-minute session in the third position in the rankings. Telephone visits fell from the Northeast and national rankings and were replaced with CPT code 90833, which is a psychotherapy visit performed with an evaluation and management service. By July, CPT code 90833 climbed its way to the fifth most common telehealth procedure code in New York State and remained on the Northeast and national lists. In both New York and the Northeast, psychotherapy visits of 45 and 60 minutes of length were the top two procedure codes conducted via telehealth in this month, although in reverse positions. In March 2021, mental health conditions continue to be #1 as a telehealth diagnosis in New York, the Northeast, and the nation, with a share of telehealth claim lines continuing to rise. COVID-19 disappeared from the top 5 telehealth diagnoses in all three areas. Substance use disorders remained on the list of the top 5 telehealth diagnoses in New York and was also included among the top 5 diagnoses in the Northeast. Nationally and in the Northeast, joint and soft tissue diseases dropped in the rankings of telehealth diagnoses, as they are largely adult conditions that were moving back to the office as COVID-19 vaccinations increased. Mental health conditions remained the top ranking telehealth diagnosis in all three locales in July, comprising roughly 68% of both the New York and Northeast diagnoses and almost 61% of all national diagnoses. Substance use disorders became the second most common reason for a telehealth visit in New York and joined the top 5 telehealth diagnoses nationally. Acute respiratory diseases and infections entered the rankings of telehealth diagnoses in New York and the Northeast and climbed to the second most common reason to seek telehealth services nationally. The increasing presence of this diagnosis suggests a return to non-COVID respiratory conditions, such as colds and bronchitis, as cases of COVID-19 fell. Here, we are taking a deeper look at which diagnoses make up the top mental health diagnoses in July 2021. As you can see, generalized anxiety disorder, major depressive disorder, adjustment disorders, and attention deficit hyperactivity disorder were prominent on these lists. We see a material distinction in the share of claim lines between anxiety diagnoses and depression diagnoses in New York and the Northeast, with anxiety comprising 34.6 and 32.3% of mental health diagnoses, and depression comprising 20.9 and 21.4% respectively. Attention deficit hyperactivity disorder and bipolar disorder rounded out the top 5 in the Northeast and nationally. Mood affective disorders was the 5th most common mental health diagnosis via telehealth in New York State. Our focus on telehealth expansion has brought to our attention the changing distribution of telehealth and office visits for mental health services. Here we are reviewing the venues for mental health treatment in New York throughout 2020 for people of all ages. In January and February 2020, prior to the spring wave of the pandemic, mental health services were overwhelmingly rendered in an office setting. In March and April, when patients avoided in-person care for fear of infection with COVID-19, telehealth surpassed the office as the preferred setting for mental health services. In April, telehealth accounted for 67% of mental health services compared to 33% for offices. This change persisted through the rest of the year, with telehealth steadily capturing between about 64 and 68% of mental health services from April to December. In 2021, telehealth has continued to outdistance an in-office setting for mental health treatment. Utilization of telehealth for mental health services peaked in New York in January, accounting for nearly 70% of all mental health claim lines. Although telehealth has remained the primary venue for treatment, we see a slight decrease in mental health services via telehealth in the summer months of this year. In July, 64% of mental health services were rendered via telehealth, while 36% took place in an office setting. This decrease in telehealth mental health services may be attributed to the rise in vaccination rates and subsequent easing of COVID-19 restrictions. We see, however, telehealth services rebound slightly in August, capturing 66% of mental health treatment. Asynchronous telehealth, which involves telehealth services that are not conducted in real time, also experienced growth during the pandemic. In both 2020 and 2021, hypertension was the most common condition treated via asynchronous telehealth in New York State. This treatment might include a patient taking a blood pressure reading at home and electronically transmitting the results to their provider for evaluation. Mental health conditions, diabetes mellitus, and joint soft tissue diseases and issues also appeared on the list of the top 5 asynchronous telehealth diagnoses in New York in both 2020 and 2021. Asynchronous telehealth treatment for mental health conditions might include blogging, texting your provider, and journal keeping, wherein the provider reads the information and the patient sends it. Interestingly, substance use disorders ranked among the top 5 in 2020, but not 2021, as the condition was replaced with acute respiratory diseases and infections. As you may know, the cost for services performed in a telehealth setting versus a non-telehealth setting can vary, both by location and individual service. When reviewing CPT code 90837, which is a 60-minute psychotherapy visit in Manhattan or GeoZip 100, the median charge and allowed amounts are higher in a non-telehealth setting than they are in a telehealth setting. For example, the estimated allowed amount for an in-person visit is $141, while a telehealth visit is $115. But as you can see, the values for CPT code 90837 are not consistently higher in a non-telehealth setting. Nationally, the telehealth charge amount for the service is $157, while the non-telehealth charge amount is $150. The charge value for the service in New York State, however, is the same between the telehealth setting and in-person setting at $150 for both. The cost for CPT code 99213, which is an established patient office visit that can be billed in an office or via electronic or telephonic methods, run higher in a telehealth setting than an in-person setting. The greatest disparity between telehealth and non-telehealth costs for the service, which is still relatively small, occurs nationwide, with the charge differential being $9 and the allowed differential being $6. If we look at the median charge amounts for this service in GeoZip 132, which encompasses Syracuse, we see that the telehealth value is $135 and the non-telehealth value is $130. Statewide, however, the telehealth and non-telehealth bill charges for this service are higher at $174 and $169 respectively. Thank you so much for this opportunity to share our telehealth data. If you would like more information regarding that data, you are welcome to visit the Telehealth Tracker on our website at fairhealth.org, and I look forward to the panel discussion that now follows.
Robin, thank you for your insights. Just as a reminder to the attendees, you can use the Q&A button at the bottom to submit any questions we'll address during the course of the presentation. As we heard earlier today, technology is top of mind. So as we start thinking about post-pandemic healthcare technology trends, thinking about opening up to Gil, Shanel, and April to have you reflect what changes and new practices that have come from the pandemic do you expect to continue in this continuing dynamic healthcare environment? So Gil, maybe I'll start with you.
Sure. Thank you guys for the opportunity to speak and join here, and thanks to everybody that joined for the conversation. From our perspective, I think there's a certain type of service that changes, but I think that the way we've always thought about it is that there's an appropriate use case for various modalities, which are all kind of encompassed within telehealth. So, and you think about what we do at RubiconMD, it's primarily asynchronous text and now, phone interactions between clinicians. There's very, very appropriate use cases for picking up the phone. There's very, very appropriate use cases for video. There's very, very appropriate use cases for in person. And I think over time, what we'll see is more of a stretching out across the spectrum and where things sit into those appropriate use cases. So pre-pandemic, we had way too many things that were happening in person that could have been handled virtually. And then I think through the pandemic, because of necessity, we swung the pendulum all the way to the other side. And I think, coming back, we'll find a medium that certainly has accelerated telehealth, probably, 15, 20 years forward. But I think that happy medium will still result in a number of appropriate things. There are certain procedures and tests and things that still need to be done in person, but I think we'll see people taking advantage of and continuing to keep modalities that are phone and video as well. And so I don't know what the right number is. I think it varies, by, like I said, by certain use case. For visual specialties, we've seen that 70 to 80% of things can be handled virtually. For lab-based specialties, we've seen that number be about 60 to 70%. For more procedural specialties, it's more around like the 40% number. And then I think for visual, for mental health services, I think the data here suggests that, we're seeing things hold steady around the 60%. So I think it varies by, specialty certainly, but the good news from what we've seen is that there's a very clear and a very appropriate use case for almost every specialty and subspecialty to be that can be handled virtually. And when you do that well, it obviously frees up the things that need to be done in person. It frees up capacity to do them. I think the only thing that I would say that is the headwind is that, I'm sure we'll get into it, the regulatory and policy side of things still hasn't quite caught up fully to be able to make it equivalent or to create the right value-based incentives everywhere.
There were some reflections on regulatory earlier today, Gil. Shanel, reflections as it relates to technology post-pandemic.
Yeah, I think that we probably really see it in two major ways. I think one, the common thread around adoption on the patient side, as Gil had mentioned, that really being leapfrogged during this COVID pandemic. And I think one of the reasons that that's so important is because really it reduces barriers to care, right? And from the patient side of things, that's always been a struggle from a population health perspective, is people's ability to engage and care proactively and pursue routine care versus allowing for conditions to exacerbate and get out of hand. So I think that that's really, one of the key pieces that will drive, this continued utilization across the board. But the other key piece, I'd say, from a government standpoint, is that I think that this is going to have a really major impact on government infrastructure and the ability for certain government entities to expand the scope of services that they provide to their communities. So, for example, Mdli, we're obviously in the 911 and EMS tech space, and expanding the scope of public safety services by enabling a virtual response tier. So that really is, one of the key ways that I see this further expanding in the future is being able to broaden the scope of services and ways that government entities can engage with the community in a proactive or preventative care standpoint.
Thank you. April.
Hi, thanks again for having me. I'm delighted to be part of this panel and learn from you all. I can speak from the perspective of the CEO and founder of a mental health company that sells mental health services to employers. So we work with some of the largest employers in the country, like PepsiCo and General Mills and Pfizer and Cisco. And we had the privilege of serving the millions of people in the country who were suffering with mental health issues throughout the pandemic and who still are. So we had really interesting data coming in throughout the pandemic around our telehealth usage. During the pandemic, we completely shut down our in-person care for mental health, and we went exclusively virtual. And we saw a 6x spike in utilization. And so some of those numbers, Robin, that you were sharing, I was thinking, we probably contributed somewhat to those numbers. And we saw a huge spike right when the pandemic hit. And then, after that kind of temporary spike went away, we saw, a very steep increase in both utilization for telehealth mental health services, but also a steep increase in employers adopting better mental health services for their employees, particularly digital health services. And so we saw just a tremendous amount of demand for Spring Health and for services like ours. And I think ultimately the trend around telehealth for mental health is going to persist. We're talking to providers now. We have a national global provider network of therapists and psychiatrists. And we have a really close pulse on how they're experiencing the pandemic. They themselves have been burned out because they've been delivering so much care and dealing with the excess demand. And in talking to them, it's very clear that a lot of these providers shut down their offices. They went out of their brick and mortar spaces and they switched completely to virtual practices. And they have no intention of going back. A lot of these providers have embraced virtual care. They find that it is much more flexible and convenient for them. They don't have to deal with the overhead of these brick and mortar spaces and with the added administrative burden of these spaces. And they're finding that no-show rates are decreasing dramatically among their members because it's just much more frictionless to receive care virtually. So even though I do anticipate, and we're already sensing this from our customers and members, I anticipate that members and customers will want to see a return of in-person care, but it's unclear whether there will be the provider supply to meet that demand for in-person care. So those are just some of my observations so far. Other things that I've noticed that I can quickly note are one, employers had a big reckoning with mental health during the pandemic. Their employees were very vocally demanding better services around their mental health. And so employers rose to the occasion and, replaced their EAPs, which frankly weren't working, with services that do work and deliver faster access to high quality care, like Spring Health, for example. So we'll see that trend continue. And we also saw an amazing trend of executives and leaders being a lot more open about their own mental health issues, leading to the mass destigmatization of mental health in the workplace. And we anticipate that trend will continue as well.
Thank you, April. Assembly Member Vanel, would you reflect on Robin's presentation and the comments of our other panelists? What role or approach would you look for government, providers, payers to play to improve patient care and address inequities in this post-pandemic world leveraging technology?
First of all, I have to say I am, honored and humbled to see the New York Health Plan Association putting this presentation together, and then hearing, it's great to hear from Robin, and then from Shanel, April, and Gil about, your experiences and what your companies are doing. This pandemic, Tom, before I get into that, this pandemic has taught us a number of things, but one of the things is, the use and the use of technology, the use of the importance of New Yorkers to be able to connect to the internet through a device, to be able to communicate with the world cannot be overemphasized. Before we can talk about, whether or not, whether we go from in-person care to virtual care, whether we go from, how much we use telehealth and how much that has penetrated in New York, we're still dealing with the reality of the digital divide amongst too many New Yorkers. And that digital divide is not only among racial and economic lines, it is in the rural areas in New York, and it is also in certain areas in the urban centers. So we still have folks that are not properly connected to the world now, and to this world that we're still trying to figure out. And we're trying to figure out how to set up what the new normal is while we're in this transition. So we're trying to figure out, what the rules are, what the bounds are, how to properly make sure that in a world where we're moving more toward using technology in healthcare, how do we make sure that can, in that transition, in that time, we can address and minimize inequities, or they'll be exacerbated if we don't figure out these underlying issues. And it sounds simple, but it's not, right? So we figured out that we heard in the past in New York, with in government, that many communities were had reliable, affordable access to data plans, to the internet. Once we found out, but when we really looked under the hood, we found out that the way it was measured was wrong, where we found out that many children could not be educated properly in a world where they had to have distance learning. If that's happening, then the forget about using telehealth. So understanding that, we have to make sure that government's role is to make sure that the infrastructure is in place, so that average people would be able to take advantage and use this, because it's about making sure that New Yorkers are healthy. It's about making sure that, one of the things that we found out that's great about your organization is that the data, we need the proper data to figure out how do we make sure that we address people's health efficiently, that we're doing a good job, that we're reaching everyone, and that we're doing it properly. So one of the things, what are we doing? We're trying to make sure that, number one, that there's access to affordable, high quality broadband across New York. That means different things or what have you, but that's something that's very important. We have to make sure too that people have the actual devices, right? So folks don't even, in New York, I believe the last time we looked at the data, it were, out of the 19 million people, there were almost, 35 million devices, right? Some people have multiple devices, but there are many people that don't have the smart devices to be able to communicate. So that's something that is really important. Another thing that we have to do is I forgot who mentioned it, but New York has to be, our state, our city, our municipalities have to make sure that we are providing services better in this new world, right? That we are also providing these services better, and that we're communicating well. One thing that's really important is, even here, we're having such a great program virtually, right? And how many people cannot, it's great that we can reach so many more people, but there are other folks that cannot be reached, so how do we figure that out? How do we close that gap? And that's something that we have to constantly do. And having this discussion with public, private, with, your organizations are something that, we must keep this conversation going to try to figure out together.
Thank you, Assembly Member. Let me open up to the group. Any other thoughts on terms of how we can close the gap of the digital divide in leveraging technology? So maybe Robin, I'll go around the horn here and start with you.
Well, I think there is that notion of there are certain sort of digital deserts that are out there that really impede people's ability to tap into these types of services. So I think it's incumbent upon, policymakers, community leaders, and public health officials to really study that more closely, as indicated by the assemblyman, in terms of some of it is a rural-urban divide, some of it are pockets within urban settings, and we could see that by looking at the patient cohorts that are appearing in our repository. And so some of that will require some flexibility on the part of providers that may have to potentially offer some telephonic visits, even though there may be a preference for video, just as people start getting plugged into that type of interaction with their provider. So I think it's something that should be top of mind, that should be studied a little bit more systematically to see, and we could tell by the codes, because thankfully the coding system for telehealth services flags for us whether it's video, whether it's telephonic, whether it's asynchronous, not in real time, and are certain people being left behind. And that's why we're trying to continue to share that data freely so that folks up in Albany and at the city level can grab that like the baton and develop some policies surrounding that.
Yeah, I'll just, add on to that as far as access to care has a lot to do with the type of devices that you have and your ability to engage in telehealth. I think one of the worst things that could possibly happen is for telehealth to become an elitist service that doesn't provide equitable access across the board. Because if you think about folks who would really benefit from telehealth, right, it's a lot of times it can be those who have multiple jobs and don't have time to take off half a day to go to a doctor's visit, right? And this can really miss them if they're not covered by the right insurer or don't have the right devices to engage in this. And as we talk to a lot of providers who do telehealth, video is not always important. I know this is a telehealth panel and it's hard to say, but it's not always important for that encounter for there to be a video component, and it can still really serve the needs of that patient as a telephonic encounter. And so, from the payer and government side of things, one of the limitations that I think puts in place really delivering patient-centered care is that there are oftentimes restrictions on reimbursement related to telephonic care, right? That video component has to be there, whether or not the patient needs it. And therefore, if the patient doesn't have that video capability, they get excluded, right? So there's a lot of kind of roadblocks like that that are unnecessary, but are put in place. And that can really limit the ability for us to democratize care by using telehealth in this way.
I think something to add is also just being mindful of, we talked about this bottleneck of devices and device accessibility, but I think also it's really important to address the provider shortage that exists, and whether or not the provider supply that exists state by state is enough to meet the demand. And the reality is that there isn't enough supply. And so just to give an anecdote, we work with a very large multinational trucking company, and they recently had a whole discussion at the executive level around our teletherapy visits for their truck drivers who are crossing state lines every single day. And so they were struggling with this concept of meeting with a provider who is licensed in whatever state that they're taking the call from. And so one thing that I would love to see to alleviate some of this burden around the provider shortage that we're seeing is the removal of these state by state licensing requirements for therapists. It doesn't make any sense in today's era where therapy is delivered mostly virtually, and it is unfortunately posing an extra barrier to mental health for millions of people.
Yeah, I would add to that. I think the points that Shanel and April made, I think, and Robin as well, are really important to characterize the problem better. I think the digital divide is a really, really important piece of it. I think we've kind of narrowed our focus on it, and I think we need to kind of broaden the aperture a little bit. We've talked about it more as the social determinants of telehealth. Because you do need to have broadband. That's absolutely what you need. And you need to have a device. But, frankly, if you don't have secure housing, you're not going to do a telehealth visit, right? And so a lot of these other things kind of come into play, even food security. Those all have to be in place for you to take advantage of all the digital needs. And so the same idea around the social determinants of health applies very much so, like when you're digitally, right? To some extent, it's more, we've I've talked to a number of the providers who had to get trained. So we're a clinician facing tool at the RubiconMD platform. And so a lot of the clinicians that use it had to be trained to do things in the home. And when they were doing also patient facing services, they had to be trained to think differently because you're now coming into somebody's home, right? And so there's, considerations around whether or not you notice abuse or, things in their environment, but also if somebody's trying to have a telepsychiatry visit or the visit with a therapist, and there are 3 generations in a 1-bedroom apartment, it's very, very difficult to be able to have a high quality private conversation. So I think just broadly, all these social considerations that kind of create an additional barrier, I think is important to understand. And then I think, to April's point around the physician piece of it, what we've seen is actually that there are 2 systems of healthcare. And so we have about 6,000 clinicians that RubiconMD supports, and it's across 37 states. And so what we saw was there's a subset of our clinicians, about half of them, that are in some form of a value-based arrangement. And for that group, they went from maybe 5 to 10% virtual to like 90 to almost 100% virtual. And then we also support about 1/3 of what we support our patients on Medicaid. We work with a few large payers there. And we saw that those numbers moved up much slower. They still got up to the same threshold, but then they dipped very quickly. And so in the middle of the pandemic, we had folks who were actually, we were working with partners in New York City. They were encouraging people to come back in for visits. And it wasn't because it was any safer. This was, last winter. It was just because they weren't able to remain financially solvent with the fee-for-service reimbursement rates that were being offered for visits. And this is thinking about the safety net and federally qualified health centers and groups that support the community. And so those are the actual groups that needed to be enabled to provide telehealth services. The other groups that were in value-based settings, they already had a lot of the technology, but there was really an underinvestment in the infrastructure for those groups, and then the payment models weren't there for them. And so I think that kind of thinking about the provider and the supply side and making sure they're actually enabled to do the work that's needed to support the communities that they're in is really important. And then the third thing I'll mention is just like a lot of, I think what's been on the digital health side is this thought around if you build it, they will come. And like, how do we build technology and these platforms and tools to be able to support folks? But the reality is when you're thinking about this from an equity lens, one of the learnings of COVID is people don't trust the physician on TV. They trust the person in their community that they know and they have a relationship with. And those people are the ones that can reach them and can have the conversations. And so figuring out the right venues and the right kind of ways to get to people and to engage patients in a lot of these communities, which were the ones that were hardest hit by COVID. And so we've talked about and thought about, how do you work with local churches, community organizations, places where you can actually get to and reach these folks so that they engage with the services. Because if we saw a lot of groups that came up with these really, really sophisticated telehealth service plans and technology and services, and then nobody used them. And you need to be able to go get to the people. And a lot of these are hard to reach people. A lot of them are housing insecure, and you got to go and figure out direct outreach plans. And so I think that third piece around making sure that you actually can reach people with the services is also really critical.
Yes, so as we reflect on the comments, I'm just thinking that as a leader of an organization that's trying to reach out to members and meet them in the communities that they're in, and recognizing the technology advances, I step back and say, what kind of skills does the future workforce require? Because we find ourselves more often than not, obviously dealing with staffing shortages. April, you talked about mental health for employees at this point in time. But when we pull our head up, we have to say, okay, we're going to be in a different spot. And what are the key skills that the healthcare workforce should have in order to meet the future. So Shanel, I'll start with you in terms of getting your reflections in terms of key skills of the healthcare workforce of the future.
Yeah, so I'll start with the probably most obvious one is they have to be tech savvy, right? I think that that's, probably the key piece is having a strong level of comfort with the tools that they're going to be asked to use. So there's going to be a big piece related to training around that. And also being able to, if the patient has issues, troubleshooting and maybe getting further into the IT realm than they've ever anticipated, as far as working and helping them through that. I think that there's partially the skill set to be developed. One of the things that Gil had mentioned is it's harder to connect with providers virtually and build that relationship. We talk about bedside manner often when we're talking about providing care. Virtual bedside manner, right, is going to be a competency to develop. How do you build that connection and that, trust with someone that you've only met virtually that might not be comfortable through that medium? That's going to be a key piece around how effective they're able to actually engage and provide that care. And then I think that, part of it is skills, but there's also resources, right? Like what resources will the workforce need in order to do this besides just the audio, video, capabilities? And part of what we've talked about with the previous, question was that when you're engaging with someone in their home through this virtual medium, you see a lot more. You get a lot more context that's richer. That's great, but can you do anything actionable around that? Once you see those sorts of things, what do you do? How do you act on it? How do you bring those resources to bear during those encounters? One of the things that we do with MDLI is not just the telehealth and piece of the technology, but it's the ability to conference in additional providers or resources, right? If you're having a telehealth encounter, can you conference in social services into that same encounter versus getting off the phone and the patient having to do that follow-up independently and it not happening? So I think that the workforce having the tools and resources to pull in parties as appropriate or pull in resources as appropriate is really going to be key for them being able to provide care in this way in the future that's effective for both the patient as well as the healthcare provider.
Thank you. April.
Yeah, absolutely. I mean, I loved so many of the points that you just made, Shanel. And, some of the pieces that we incorporate into our practice are things like tech savviness. We actually test our providers who we admit into our network for their tech savviness. They are expected to have a baseline level of savviness around technology in order to engage with us. The second thing that totally resonated with me was your point about bedside manner. We vet for that as well. But, as you were talking, I was thinking to myself, we've previously thought about bedside manner in a very physical way. And, we very naturally have adopted, virtual best practices, but we should start, I was thinking just for my internal team, we should start marketing this as like virtual bedside manner best practices. And, some of those best practices include waving at the beginning and the end of a call. I mean, it sounds kind of arbitrary, but there's a lot of research to show that if you show your hands, people feel safer psychologically in meeting with you. We also mandate to our providers, taking the call from a computer versus a phone so that there isn't that wobbliness and that shakiness that could throw someone off who frankly needs, a little bit of calm and stability within their therapy session. So these are just a few examples of virtual bedside manner. And these are things that we vet for, but also train our providers on. So many points that you just said resonated with me. But in terms of, some of the other pieces that we're hearing about as necessary for building the skill set of the future healthcare workforce, I would say also, being able to vet digital tools and use clinical decision support. So, these technologies are new. But they're being, rapidly adopted now, and the pandemic has helped. I'm finding that providers want to adopt digital tools within their practices, but they are having a hard time vetting which tools are clinically validated, which digital therapeutics are clinically validated. They're having a hard time interpreting the data that is surfaced to them from clinical decision support tools. So training around the vetting of these digital tools and the use of these digital tools, I think, is incredibly important. And then finally, kind of we practice what is gold standard within behavioral healthcare, which is measurement-based care. So this is not a digital practice. This is actually an analog best practice, but it is very amenable to digital care. And measurement-based care is essentially the use of patient-reported scales around your depression or anxiety or whatever mental health condition you have, and it's around using kind of these clinically validated scales to understand how the patient is doing from a self-report perspective, and using these scales within your practice, and using the data before, during, and after sessions to maximize the time that you have with the patient. And so, with virtual care, you lose kind of the magic and the entire kind of experience with the in-person encounter. But what you can get with digital care is a variety of tools that give you a lot of data that can help you best support the individual. And so training around the use of this data to augment each provider session is incredibly important. So those are just a few ideas that come to mind when it comes to building the skill set of the future workforce.
So April, you picked up on data, and we heard that in a previous conversation earlier today. More data, good data. I'm going to pivot for a second, given that our panel is time is running short, but talk about privacy of the data, and how do we ensure that the data is being used appropriately at the same time maintaining privacy. So maybe Assembly Member Vanel, I'll start with you and get your reflections.
Wow, first of all, this is such a great panel. I'm sitting here learning and hearing all this. I'm really excited to see all the participants also learning from everyone here. And just hearing, it was refreshing to hear how your companies and industries are looking at how to train the workforce for the future of the workforce and what that's going to look like. Hearing, we've always heard about in-person skills and soft skills. Now there's digital soft skills. My goodness gracious, it makes sense. So I'm very happy to hear this. Privacy. Where do I start? One of the things that's really interesting to look at when it comes to policymakers globally in this country and in the state is we're still trying to figure out what the bounds are when it comes to data. What it means, what does privacy mean? What are the different zones of privacy? How do we properly, what are the proper bounds? How, should we deal with, should this only be on the national level? What if the Congress and the federal government doesn't pick it up? What should we do in the state? There are states that are, wrestling with these issues now, right? California passed a law. In New York, we're wrestling on how to do this. How do we possibly make sure that we keep, we keep the proper bounds of privacy with people's different and companies and institutions and organizations and entities and governments, different relationships to different levels of data. It is very complicated. But one thing that's not complicated is that in the health field, right, privacy is key. We have a major issue in the world with cybersecurity, with ransomware. In New York alone, we were dealing with many of our health institutions being falling victim to ransomware and to other cyber crimes. And just recently, I found that our laws are not adequate enough to cover all of this. So we're still in the process of writing new laws to make sure that the bad actors are held accountable. But we also have to make sure that we have the proper bounds for healthcare providers to make sure that, that you guys are storing information properly, that you guys are transferring information properly, and the different kinds of processes and protocols and regulations are in place for data. For the most part, many of our institutions are doing a good job online. But again, we're still in the process of making sure we strengthen what those laws and regulations are, and that we have clear rules around this data. But Tom, this is we are in the midst of a dynamic time to figure out, what privacy means online. We have a number of bills. I'm not going to talk specifically about my bill, but we have a number of bills in the state and around the country to address privacy.
Thank you, Assembly Member. Maybe Rob, I'll close with you, given the 35 billion claim records, how you reflect on data privacy.
Sure. Well, the way we become stewards of this 35 billion is to make sure that we have both physical custody in a secure manner in terms of the physical claims, but also in terms of data use policies, in terms of making data available in ways that protect the interests of both the contributors, but also thread the needle to inform the public and patients and providers with the information they need to inform the next generation of the healthcare workforce. And I'm sure all of the folks here on this call are, diligent in terms of the HIPAA training and just educating and training in an ongoing way, not just once, but repeatedly, their employees about all the sensitivities and the nuances associated with privacy, and just using common sense practices to make sure that conversations being held in private ways, that data is being secured, as I said, both physically and with all kinds of protections at different layers and firewalls. And I think we're all attentive to that, because that is really the key. That's really the oasis of information that we all need to continue to really advance the healthcare of the patients.
Thank you. Eric, at this point in time, I'm going to close out the panel, and I want to take the opportunity to say thank you to the panelists, your reflections, technology post-pandemic. I do agree that there was a lot shared here in terms of addressing the digital divide, upskilling our employee base, and at the same time, reflecting on the conversation to say it's real important to still use our eyes and ears, beyond just the technology. And more often than not, understand the individual's environments, because unfortunately that drives one's healthcare outcomes. So appreciate the conversation and how technology can supplement and enhance and engage the member and the payer experience. So Eric, I'll turn it back to you. From you.
All right, great. Thanks, Tom, and thanks to all the panel. Before I let you all go, Robin, as I've told folks before, I think we've got a great friend in Fair Health. There's probably no better data resource that we utilize and rely on. So we appreciate your work today and the presentation. And for our new friends, Shanel, Gil, April, really some great points today that we'd love to have you all come back at some point, because we certainly didn't cover everything that we wanted, that we could have covered during the course of this hour. But certainly a lot of things to think about around how do we address inequities, what can we do to ensure the workforce going forward, and just love the whole notion of sort of the digital bedside and having the skill set there. And Assembly Member Vanel, we appreciate your time. We certainly look forward to working with you in the upcoming session, you and your colleagues, on these issues and others to ensure high quality, affordable healthcare for all New Yorkers. So with that, I just want to thank all of you again for joining us today. We're going to kick off again tomorrow at 10 a.m. We have 3 great panel sessions, building a more inclusive and equitable healthcare system, consumer decision-making in healthcare and the role of transparency, and our sponsored session, Innovative Insights for Understanding VBC and Dental Practices, presented by DentaQuest. You're not going to want to miss a minute of it, so just make sure you log on early tomorrow. And thanks again for joining us. And Tom, thank you again for moderating today's panel. And we look forward to seeing everybody back here tomorrow.
Thank you, Eric. Take care.